We start our instruction course on surgical management of pterygium, simple and difficult cases. I am Dr. Shantanu Mitra. With me, my co-authors are Dr. Kushal Banerjee and Dr. Vartendu Bhushan. We work at Disha Eye Hospitals, West Bengal. One of our speakers couldn't come here, so her topic will also be delivered by Dr. Vartendu. We do not have any financial interest with the subject matter or methods mentioned here. This is probably the best possible comprehensive definition about pterygium I could find. Pterygium is a wing-shaped corneal incursion of an aberrant conjunctival wound healing response characterized by the centripetal growth of an altered squamous epithelium with goblet cell hyperplasia and an underlying stroma of activated proliferating fibroblasts, neovascularization, inflammatory cells, and extracellular matrix. However, the precise pathogenesis remains unclear. It is most commonly found in the peri-equatorial latitudes in this amount of percentage, mostly around the 30-degree equatorial region. The symptoms of pterygium are dry eye symptoms, vision disturbance, cosmetic, and sometimes diplopia. It was long back described by the great Indian physician Shushrut in 600 BC and later on documented by many other scientists and doctors. Surgery is the only curative treatment, and recurrence has always been the key issue in any pterygium surgery. The etiology and pathogenesis, there are so many theories and postulates regarding the formation of a pterygium, but the most accepted of these are the two. One is the UV radiation due to cumulative effect of absorbed UV rays by eye surface, and the limbal theory where the migrant keratoblasts are described which originate from limbal stem cells leading to pterygia. So the current concept of pathogenesis is UV light forms free radicals that induce damages in DNA, RNA, and the extracellular matrix of cells. UVB induces expression of cytokines and growth factors in pterygial epithelial cells. Polymorphisms of the DNA break repair gene Ku70 have been associated with genetic predisposition to pterygia development. An increased level of T cells and inflammatory markers have also been noted in pterygial tissue compared to normal conjunctival tissue. All these findings suggest that pterygium is not just a degenerative lesion, but could be a result of uncontrolled cell proliferation. So our aims and options of pterygium surgery, the aims are basically to restore an uninterrupted refractive surface and to reduce the recurrence rate. There should be minimization of serious complications with the procedures involved and a satisfactory cosmetic outcome. The surgical options available are a simple excision, that is also known as the Bayer-Sclera technique, excision with tissue grafting like conjunctival autograft, amniotic membrane transplant, or a combination of both, and adjuvants like MMC, 5-FU, and a few others also. They can be also joined with a simple excision technique or with tissue grafting. Now, regarding the surgical procedures, there is a long history of different surgical procedures, but conjunctival autografting, excision of pterygium with conjunctival autografting is currently the procedure of choice for both primary and recurrent pterygium with good cosmesis, a low recurrence rate, and no fatal complications. And this was a history of different types of pterygial surgery, but after the publication of Kenyan's data in 1985 regarding the current conjunctival autograft transplantation, this is the most accepted surgical procedure of choice. And often we find wide variations reported with different surgical procedures in the recurrence rate. Actually, these depend on many factors, and basically to come at one single recurrence rate with one procedure is very difficult to postulate. So with this introductory thing, I introduce now Dr. Kushal Banerjee, who will be talking about conjunctival autografting in simple pterygium and is the technique of CAG and its variations. Next, Dr. Vartendra Bhushan will be talking about the hurdle of double pterygium management and recurrent pterygium management. And then we will take up some newer advances in pterygium surgery and some of the course. Please, Dr. Kushal. Thank you.
Thank you, sir. A very good afternoon, everybody. I would like to thank AIOC for giving me this platform. I have a few words to highlight upon the conjunctival autografting in case of simple pterygium, the techniques of CAG and its variations. I don't have any financial interest in this. So, first of all, we should know when to do a pterygium surgery. So, when a progressive pterygium is encroaching the visual axis, leading to a gross induced astigmatism, followed by chronic inflammation and ocular movements gets restricted, we should go for surgical. Now, the following are the few wound closure options which are available from the arm. The first one is the Bayes sclera. It was first done by D. O'Brien in the year of 1948. In case of smaller defects, simple closure can be done. L-shaped sliding flaps, U-shaped rotational flaps are also practiced. And last but not the least, the free graft from preferably the superior bulbar is the conjunctival autografting. Now, our topic of interest is CAG, the conjunctival autografting. Due to its efficacy and long-term safety, CAG is the procedure of choice in nearly all types of pterygium surgeries. It was first published by Kenyan et al. In the year of 1985. What is the aim? The aim is to replace the area of pterygium with a healthy piece of bulbar conjunctiva to cover the raw bare sclera area. The rationale behind doing a CAG is restoring the limbal stem cell barrier, which inhibits the fibrovascular proliferation and thus having the lowest recurrence rate among the all non-adjuvant techniques. The size, thickness, vascularity, the grading, corneal involvement, the amount of induced astigmatism, all are measured before surgery, and the tear film are assessed to rule out dry eye disease and ocular surface disorders. The surgery is usually performed under topical anesthesia with subconjunctival lignocaine. Sometimes posterior subtenons, xylocaine, bupivacaine can also be given. In case of very uncooperative patients, perivalvular anesthesia can also be used. Now, coming to the surgical steps proper. The head of the pterygium is avulsed using some tooth forceps in a circular fashion called pterygiorexis. We will go to the surgery proper, so it will be easier to understand. First, the head is avulsed from the cornea using a pterygiorexis forceps. We can also use Tooth's knife, blade or spatula to separate also. And once it's separated, the body is excised along the episcleral plane with Westcott scissor. The corneal and the limbal area is polished with diamond bar, and the base of the pterygium usually is excised approximately 4 to 6 millimeter from the limbus proper. The fibrovascular tissue is thoroughly removed, and the scleral bed created can be cleaned up by crescent blade. Also, the diamond bud is used for the corneal and limbal areas. There should be very minimal amount of cautery to avoid the ischemia, and hemostasis should be carefully achieved. And this is the fibrovascular part which is removed, and a little bit of trimming of the external conjunctiva. Now, once the pterygium is removed, we come to the next step, that is the harvesting the graft, the conjunctival autograft. Preferably an approximate 0.5 to 1 millimeter larger area in all dimensions than the bascular area should be taken up, and that the choice of area is superior bulbar conjunctiva, and followed by a graft orientation. We come to the surgery proper. A free conjunctival graft, preferably approximate, as I told, it will be little bigger than the bascular area. The thin tenons free graft is very essential. There is a special type of forceps designed by a fellow colleague, Dr. Ayan Mohanto, where we lift up the conjunctiva, the graft area, bloat it with normal saline, and then try to dissect out with crescent blade, try to make it as tenons free as possible, and once that is done, we cut the area, put it on the cornea, orient it properly. The limbal edge should be aligned with the recipient limbus. The limbal area of that should be around with the recipient limbus, and the correct epithelial surface should be oriented, and preferably we should make sure that the graft is not inverted. There are a few variants of CAG. There are small area. To cover a small area, we can go for mini conjunctival autograft, the limbal conjunctival autograft, the CLAG, sometimes limbar epithelial autografts, the slate, sliding flaps are also done. The conjunctival rotation graft, the CRAG, sometimes associated with amniotic membrane, and Macrae first did that transplantation of the pterygium head below the conjunctiva away from the limbus. We will be highlighting on CLAG and CRAG later on. Now, CLAG mainly focuses on the presumed limbal stem cell deficiency in case of pterygium, and it includes the limbal stem cells in addition to the conjunctival graft. The principle is it acts as a barrier to the conjunctival cells migration into the corneal surface and thus prevents the recurrence. And usually the limbal conjunctival graft includes around 0.5 millimeter of the limbus in case of the peripheral cornea. As we can see from here, this distance should be 0.5, and this graft preferably should be 6 millimeter, and the depth of this should be 100 micron. So, going to the surgery proper, the conjunctival graft should be 6 millimeter as well, and the thickness of the limbal area is 0.5. We use a 15 number blade to make a groove, and again after lifting the conjunctiva and bloating the conjunctiva with normal saline, we try to dissect out the conjunctival graft to make it as much tenons free as possible, same like CAG. And once the dissection part is complete and we are thorough with the removal of the tenons thing, we go with the crescent blade. We can use the crescent blade also to peel off the tenons thing from the conjunctival autograft. The next part is very common with all of us performing SICS. It's just like we make a tunnel, we use the crescent blade, go little deep, we have already made a groove with the blade, try to reach up to the groove, that is approximately 0.5 millimeter inside the limbus. And as we can see, we are removing and making it tenons free with the crescent, peeling off the tenons, and once it's done, it's using the crescent blade, just like making SICS tunnel, little deep we can make out, we can tent up the conjunctiva graft with the non-tooth forceps so that we can have a visualization, and once it's done, we excise the graft and then we put it on the cornea just like CAG, orient it properly, and then slowly, once it is we reach the area of groove, our desired level, we will go for the dissection of the graft, and once it is dissected out, we will put it on the cornea, make it oriented same as CAG. The limbal area side should face the limbal side of the raw area, and once it is oriented properly, we will hold it with the forceps and put it in the raw area and then align it properly. But multiple studies and head-to-head trials have concluded that CAG is no better than CAG. CLAG is no better than CAG. So, but technically it's more demanding, it's more time consuming to perform, and there is a potential risk for limbal damage in case of the donor side. So, coming to CRAG, the conjunctival rotational autograft. It is usually indicated when both the superior and inferior bulbar conjunctiva are unfit to take a graft, as well as the opposite eye there is some contraindication for graft harvesting. Here we make a 180-degree rotation, as we can see here. The A part goes here, the B part rotates, so it's like an 180-degree rotation of the area. First, the redundant conjunctiva is marked, which is to be dissected out, and then just like the previous procedure, it's slowly dissected out, make it tenons free as much as possible, and once it's on the cornea, we shouldn't lose the side, because otherwise we might lose the orientation. That is the limbal side, and previous two cases the limbal side was going towards the limbal side. Here the limbal side will go towards the canthal side. That is the difference. Here we can see. And after the graft is made tension free, it is placed properly. And here the limbal side was it was here, it went this side, canthal side. Now at times it becomes really tricky and tedious to get a clean tenons in case of this crack, and as because we have got very small amount of conjunctival tissue left for the graft, so in case of bigger pterygium the raw area is more, it's not at all advisable. Now all the process of taking out the pterygium is done, all the process of taking out the graft is done. Now how to fix the graft? There are a few methods. We either can attach it with a suture, the fibrin glue, the electrocautery, and the autologous blood, named after Mitro's surgery, after our Chief Inspector Dr. Shantanu Mitro, and he will discuss it later in his talk. Now coming to the suture, we preferably use 80 or 10-0 Vicryl. I preferably use 80 Vicryl. While suturing, the limbal edges should be fixed first, and it should be anchored. Otherwise, the graft might get dislodged or dislocated, and this is followed by the circumferential fixation of the other part. And I am really indebted to Dr. Mohanto for allowing me and giving me the permission to share his videos. Next, we coming to the glue. It contains two components, the fibrinogen and thrombin. First is the sealant protein, which is composed of human plasminogen, fibrinonectin, factor VIII, which is reconstituted with human apoprotein, and the sealant setting solution, which is composed of human thrombin constituted with calcium chloride. When both are mixed, there is a cross-linking, and that gives the adhesive property. It is also available in case of duplojet, like both the things together and comes in the same syringe. The two components are preferably first dissolved in a solution and they heated at 36 degrees for preferably for 10 minutes, which prepares the glue, and then we start the application. The thrombin, after once the graft is ready, we orient it properly, then make it as much dry as possible with sponge, both the surfaces, and then thrombin is applied sparingly on the bare sclera area, and the fibrinogen is applied on the back side or stromal side of the graft. Then the graft is inverted, leading to mixing of those two material. The edges of the graft are then approximated with forceps, and if any excess graft is there, it should be excised, and thus the graft adheres to the sclera with the formation once the fibrin clot is formed. As we are seeing, we are approximating all the edges as much as possible, and thus by that time we approximate, it gets fixed. Now glue has few advantages of the sutures, like it reduces the pain, saves time, cuts down the postoperative inflammation, minimizes the recurrence, and prevents the graft dislocation. Autograft can also be welded circumferentially with electrocautery pen, and latest by autologous blood, as I discussed. It's named under Mitra surgery, and Dr. Mitra will discuss it in his talk. Topical antibiotic, profuse lubrication, tapering of steroids are used in postoperative period, and the proper follow-up should be there to look out for earliest detection of recurrence, if any. The following are the intraoperative and the postoperative complications which are encountered. Namely, due to extensive damage, there is some scleral corneal damage, medial rectus injury, excessive bleeding can be there, some globe rupture, and canalicular damage. Buttonhole is very common. Graft loss or displacement is also there. In case of postoperative, recurrence is the commonest. There is graft edema retraction, the Sins necrosis is there, pyogenic granuloma formation, Dellen, suture granuloma, subconch hemorrhage, they are commonly encountered. Though being CAG one of the safest, these are very less than the others. Now over dissection can cause some accidental perforation in the graft, and it causes a buttonhole. If it's small, it can be managed by suturing. If it's a big one, we should have to reharvest. The tenons, if not removed properly, can cause graft edema, which subsides with steroid drops. If the graft size is smaller, if there is weak adhesion due to improper suturing, or the glue not working properly, or the glue not prepared properly, the graft can retract from the proper side, and it can be corrected with a bigger pentagonal size graft and followed by good adhesion either by resuturing or regluing. Sometimes overzealous use of cautery and MMC exposure also cause graft necrosis. Even it can lead to melting of the graft and sense. They are preferably managed by steroids, sometimes patch graft with or without embryonic membrane, and also a partial thickness scleral graft can be taken as an option. Excessive bleeding might sometimes leads to hematoma, which subsided usually by its own. Delen can arise due to overuse of the cautery or diamond bar. This also subsides with lubrications. Inclusion cyst, pyogenic granuloma, stitch granuloma, they can also arise occasionally, and all of them needs excision. Now, amongst the three commonest method of Bayes sclera, CAG with sutures and CAG with fibrin glue, CAG with glue has the minimum recurrence rate of less than 5%. So, the star attraction of CAG lies in the lowest recurrence rate, the excellent cosmesis, and minimizing the need for antimetabolites. So, our take home learning will be CAG is the gold standard when it comes to pterygium surgery. Good surgical technique reduces the recurrence rate, and it's very essential tool for all and every ophthalmologist armamentarium. Thank you for your patient hearing. ভূষণটা খুলে দিচ্ছি। डबल ठीक है, डबल खोल दो। यहाँ जाना, इसको क्लिक करना, ये ऑटोमेटिक आ गया, ठीक है। लेज़र ऑन करना है तो ऑन करके रख देता हूँ, पीछे से ले लेना, ये लेज़र नीचे आकर्षण जरूरत है तो उठा देना, एरो जाने से।
So, good afternoon everyone. Thank you Santanu sir for including me in this course. My topic is hurdles in management of double pterygium. So, in this presentation I will give introduction, indications, preoperative hurdles, intraoperative surgical hurdles, postoperative challenges, and patient related challenges. So, everyone knows that pterygium is a degenerative fibrovascular growth of conjunctiva extending onto the cornea. Double pterygium refers to involvement of both nasal and temporal sides in the same eye. Progressive encroachment from both sides can induce astigmatism, and that can significantly affect visual quality. Early surgical intervention may reduce permanent corneal distortion, and repeated episodes of inflammation indicate active disease. So, chronic inflammation increases patient discomfort and may accelerate progression. In such cases, surgery helps both in symptom relief and in preventing further corneal involvement. From a cosmetic scenario, visible bilateral growth often causes psychological distress. So, particularly in younger or working individuals. In such cases, surgery may be justified even in the absence of severe visual loss. Restriction of ocular movement is rare because of the conjunctival fibrosis. Finally, before ocular surgery, removal of pterygium is recommended. Before we proceed to surgical options, we have preoperative hurdles. So, what are these? The preoperative assessment must include tear film evaluation, limbal status, and corneal involvement. Careful planning is required to determine whether adequate conjunctiva is available for dual grafting. We must preoperatively decide single large conjunctival autograft or two smaller graft or amniotic membrane transplantation or a combination technique. In previously operated cases, scarring alter tissue planes. This makes dissection difficult and increases graft related complications. Dry eye disease is common in these patients. Poor tear film stability can compromise graft adherence and epithelial healing. Systemic and patient factors. Diabetes may delay wound healing, and outdoor occupational exposure increases recurrence probability. So these factors must be addressed preoperatively. A preoperative decision is whether to perform staged surgery or single surgeries or simultaneous excision of both heads. This depends on conjunctival availability, inflammation status, and surgeon expertise. Need proper counseling about possible redness during healing as cosmesis is concerned. Now come to intraoperative or surgical hurdles. In double pterygium, we are operating on both nasal and temporal sides in the same sitting. This significantly reduces working space. There is a large bare scleral defect. Excision of two pterygium creates extensive scleral exposure. So this demands either a large conjunctival autograft or two separate grafts. Planning graft dimensions preoperatively is essential to prevent under coverage and recurrence. This one is the large bare scleral area. Limited donor conjunctiva. Basically, we took superior bulbar conjunctiva is our preferred donor site. However, in double pterygium, excess tissue availability may be limited, so excessive harvesting risks limbal stem cells deficiency in selected cases, and amniotic mammectomy may be considered there. Second is increased bleeding during surgery. So double excision increases vascular manipulation, leading to more bleeding, while cautery is necessary. Overuse can delay epithelial healing. This is the video showing how I can stop bleeding. I have just cauterized preoperatively before excision of the conjunctiva. After fibrovascular tissue excision, there is a bleeding. Then another one is we can cauterize a little bit, just pinpoint cautery, and second one, there is adrenaline soft swab is given inside the pocket of the tissue. So hemostasis must be balanced and meticulous. Thus I have given adrenaline soft swab to stop the bleeding. Next is fibrotic adhesion, especially in recurrent or long-standing cases, make corneal dissection technically demanding. So there is a risk of corneal thinning, buttonholing, irregular or stromal surface, which can affect visual outcome. Video नहीं चल रहा है. So this is the much adhered corneal part. It took too much time. I have scrubbed the corneal part by 15 number BP blade, and another option we can use diamond burr, which decreases the time and make surface more smooth. So maintaining limbus to limbus orientation on both sides is technically demanding. So any inversion or misalignment increases recurrence risk. So when using fibrin glue, timing and positioning become even more critical because two grafts must be secured sequentially. This is the graft I have taken from superior part. Marking is done. Next graft is clear from the limbus. Graft is spread over the cornea. As this is the double pterygium, so there is a large bare sclera. So graft is cut in horizontally. I have cut the graft into two parts. And both is one part is given the bigger one is given to the nasal where much more pterygium was there, and a smaller one is given to the other side. Here fibrin glue is used. So this process prolonged exposure increases ocular surface dryness and stromal edema, which may compromise graft adherence. And there is excessive conjunctival manipulation can predispose adhesions between conjunctiva and eyelid. So grafting is done. So then come to the surgical technique. What technique we should take? So one is CAG or limbal conjunctiva. While limbal conjunctiva autograft offers the lowest recurrence, performing two precise grafts is technically demanding. So challenges include maintaining correct limbal orientation, preventing graft inversion, ensuring uniform thickness, avoiding graft retraction, and in double cases surgical precision becomes even more critical to prevent asymmetry and recurrences. Here we can use either horizontal graft or this one is the vertical graft. But vertical graft, limbus to limbus is maintained, but there is a gap between side by side. And this in horizontal, there is one side we can maintain the orientation, but other side we cannot maintain. So limited donor conjunctiva is a major limiting factor in conjunctival autograft. Another is amniotic membrane graft, useful when conjunctiva is insufficient, lower recurrence than bare sclera but higher than CAG. Cost and availability is a major concern. Bare sclera is nowadays not done because of the high recurrence rate. The combined techniques is useful. Challenges increases in surgical time, cost and complexity. Use of adjuvants risks of complication is more if used if misused. So if we have limited conjunctiva, may require AMT or combined approach. Higher recurrence risk, prefer limbal CAG. Large defects, consider split graft versus stage surgery. If future glaucoma risk is there, so avoid excessive superior harvest. This is the pre-op and 1 week post-op photo of double pterygium, that the video that I have showed. So the post-operative hurdles become recurrences, the excessive inflammation, graft retainer complications like graft edema, graft retraction, graft loss or displacement, granuloma formation, corneal complications, scleral complications and steroid-related complications. Patient-related challenge becomes poor follow-up, excessive sun or dust exposure, rubbing of eyes, or irregular use of post-operative medicines. So in conclusion, double pterygium surgery is more technically demanding than single pterygium excision. Proper case selection and pre-operative planning are essential for successful outcomes. Meticulous surgical technique and careful tissue handling minimizes complications. So appropriate post-operative care and follow-up play a crucial role in recurrence. Thank you. Should I continue? Pterygium recurrence is the commonest undesirable outcome of pterygium surgery, ranging from 1 to 40% depending upon techniques used. So why a different ballgame? Recurrent pterygium is not just a repeat of the primary disease. It is biologically more aggressive. So what are the surgical options? First, conjunctival autograft, limbal conjunctival autograft, amniotic membrane transplantation, conjunctival rotational flap, combined techniques or adjunctive therapy. A conjunctival autograft, as in 1985 Kenyon et al. So surgical technique was found to be safe and effective in reducing the number of recurrence and while avoiding the risk of potentially serious complications. A limbal conjunctival autograft offers an added advantage by restoring the limbal stem cell barrier. A study done by Alpha showed limbal transplantation appeared more effective than free conjunctival transplantation for treatment of recurrent pterygium. Now the amniotic membrane transplantation AMT has an anti-inflammatory and anti-fibrotic properties. When used alone, recurrence rates are higher compared to conjunctival autograft. Its real value lies in complex cases, large defect, double-headed pterygium or conjunctival deficiency. This is the video showing the grade 4 recurrent pterygium. This is already surgery is done, so the conjunctival corneal part is too large, so that is smoothened by diamond burr. Then amniotic membrane is put over the corneal part and sutured. Sutured. And in complex cases like simplified management, careful dissection, AMT plus MMC for initial reconstruction and is done. Restrictive establishment same. In double recurrences or multiple surgeries, conjunctiva are often deficient. So options include AMT, oral mucosal graft or conjunctival allograft. So in adjunctive therapy, which suppresses regrowth of pterygium tissue, include irradiation, thiotepa or topical mitomycin. Recurrence rate is 0 to 12%. Beta irradiation, the complications include scleral thinning, ulceration, infections and radiation-induced cataract. Thiotopa is recurrence rate 0 to 10%, 8%. Complication include depigmentation of skin and dry eye. Other adjuncts like 5-fluorouracil and anti-VEGF agents have been tried. While they may reduce vascularity and fibroblast activity, evidence supports their role only as adjuncts, not as standalone therapy. Now, mitomycin C is a powerful antifibrotic agent. Used judiciously, it significantly reduces recurrence, but it comes with potential devastating complications such as scleral melt and necrotizing scleritis. Therefore, MMC should be used selectively, but never routinely. This is the complication. Mitomycin is considered superior than other as far as recurrence is concerned. So, single use per operative considered better in reducing the toxic side effects. This is the complication of scleral melt is there. If we compare the recurrence rate, bare sclera has highest, CAG has 5 to 15, LCAG has 5 to 10, AMT alone 15 to 30%, and combined with MMC it is 2 to 8%. So how can reduce recurrence? Some practical plus minimum criteria: large graft size, correct limbal orientation, and aggressive post-operative steroid therapy. So post-operative regimen should topical steroids, lubricants, UV protection, control of dry eye, monitor at week, 1 week, 1 month, and 3 months. Some complications to watch for are graft edema, retraction, formation, scleral thinning, Dellen formation, scleral thinning, secondary infection. So algorithm for management is primary recurrence, we have to go for conjunctival autograft with tenonectomy. Large defects should limbal conjunctival autograft. Multiple recurrences, conjunctival autograft with MMC, and conjunctival deficiency MMT plus minus MMC. Simpliferone, AMT, and reconstruction is needed. So recurrent pterygium is biologically more aggressive. Surgery must address fibrosis and limbal failure. CAG remain gold standard. MS is powerful but double-edged, so surgical precision determines outcome. Thank you.
So after some large technical talks, we come to the concluding part of the course. I have named it Newer Advances in Management of Pterygium, but really, since Kenyan's conjunctival autografting introduced in 1985, surgical technique, no new surgical technique has come up really. Only modifications in the surgeries or modification in the graft fixation techniques have been introduced, which may be helpful in further reducing the recurrence rate. No financial interest to disclose. The things we can use or discuss here are the adjuvants, which have already been discussed by Dr. Vartendu in details. So I am going to concentrate on the use of various tissue adhesives or modification of tissue adhesives that we have. We have fibrin glue, we have autologous blood, and very recently we have we are using Botroclot as tissue adhesive. So this is the principle of coagulation. We all know how the fibrin clot is formed. This principle is has been used in the synthetic tissue glue, fibrin glue that has been prepared for tissue fixation or graft fixation. So if it can be done synthetically, why not it can be done naturally? Autologous blood was already being used by drawing patient's blood 2 hours before the surgery, then centrifuging, separating the serum and using that serum, but it was a long procedure. So we thought that why not use the natural blood clot that is formed during the surgery over the over the wear area, and use that as a tissue adhesive. So this is the surgery I am showing with autoblood graft fixation. After harvesting the graft, by that time we allow a thin blood clot to form over the recipient bed, and then using that blood clot as a tissue adhesive, we fix the graft. The prerequisites for a successful surgery with this procedure is a very thin blood clot should be allowed to form. There should be no active bleeding on the bed. If it is there, you have to cauterize that. The graft should be thin and tenon free, slightly oversized so that there is no retraction, and thorough edge to edge graft apposition. This is very important. You take here at least 4 to 5 minutes time, point to point. Usually use two forceps side by side, one tooth forceps and one plain forceps, and in different throughout the circumferential length of the graft, you use this technique and take that 3 to 5 minutes time to allow the graft. And the last two headings are perivalvular anesthesia and post-op eye patching. I prefer because of lead immobilization in the immediate post-operative period, so that the graft is not dislodged from the bed easily. So after this, I am using this technique since 2010, and since 2010 I have stopped applying any sutures, because it has been also shown that suture induce more inflammation and more higher recurrence rate. So either tissue glue, fibrin glue, or autoblood. And very recently I am using this Botroclot. I have started using this Botroclot. I have done 12 cases till now. Dr. Harshul Tak from Jaipur only, he is using this technique for a longer period of time. Maybe few other surgeons are also using. Botroclot is actually a hemocoagulase based agent derived from snake venom. Okay, it's an active ingredient is the venom derived hemocoagulase, and this releases fibrinopeptide A or B to form fibrin monomers, forming a solid polymerized clot, and the enzyme activates factor 13A, stabilizing the fibrin mesh. It is available as topical solution of 10 ml or 15 ml pack, and the main problem is that you can only draw it from with a sterile syringe and use it at one sitting only, because otherwise you can't maintain the sterility of the rest of the solution. So at that one sitting you can do multiple pterygium surgery if you can do that. Otherwise you have to do one surgery at a time. And this is the application of the Botroclot. Just like autoblood, you have harvested the graft, aligned by the side of the recipient bed. You can cauterize the area from where the graft has been taken, and then the Botroclot solution, which we have drawn from the bottle with a sterile 1 ml syringe, is a single solution, not like glue. Just put that solution over the bare area. And then you flip over the graft, and again point to point apposition with two forces, but it takes faster time than autoblood, but more time than fibrin glue. Fibrin glue acts fastest between the three process. But here you, in the autoblood, you get a very bloody picture of the surface. Here it's more clear and more cosmetic right from the day one. And it's definitely the most cost effective tissue adhesive. So here are the comparative scenes I have just shown in sutures, glue, autoblood and Botroclot, day 1 and day 30. The last one is the Botroclot. I will still need a few more cases and longer time to say what's in the long run, how it acts. Now a few special situations. One is cataract with pterygium, whether you should do a simultaneous surgery or a sequential surgery. Simultaneous surgery is definitely helpful for the patient, because at one sitting he gets rid of two problems. But if you can get a smaller pterygium or you can get a larger pterygium, and the larger pterygium sometimes produce excessive corneal astigmatism. And today the cataract surgery mostly done with premium lenses, so if you get a wrong lens assessment, then you are in a soup. So in those cases, I did one study, and it's also been published that more than 2.5 to 3 diopter corneal astigmatism is shown preoperatively is definitely risky for an IOL calculation. So in those cases, it's better that you go for a sequential surgery. First, the pterygium should be done, and after 1 month, at least 1 month to 1.5 months gap, then you do a biometry, again a corneal topography and biometry, and then it's you are more sure that you are putting the right IOL in. So if you are doing a simultaneous surgery, then you first excise the pterygium, make the bare area, make the bed, and then you complete your cataract surgery, put the IOL in, do the corneal hydration, and then you go for the graft harvesting and fixation of the graft, either by tissue glue or whatever technique suits you. And this is another unique technique. I am very much grateful to my colleague Dr. Tuhin Chaudhary, who is present here in the audience. He does this surgery most of the time. Sorry. This is called mini slit, that is ipsilateral simple limbal epithelial transplantation, which is after doing the excision of the pterygium, the AMT is used to cover the bare area. Kushal, video. বন্ধ করে ওখানে যে আমার এটা আছে দেখ মিনিমাইজ কর এটা চালা এটা চালা So after excision of the pterygium, then the bare area is covered with a amniotic membrane graft, and then 2 by 2 millimeter of limbal tissue is to be harvested and cut into 8 to 10 pieces. Those pieces are put over the amniotic membrane in the orientation of the limbus and fixed with glue, and then that should be covered with another amniotic membrane or BCL. Going 0.5 millimeter inside the limbus to include the limbal stem cells. And these are the small cut pieces of the tissue put over the amniotic membrane along with the limbal orientation, and then you cover them with another AMT or BCL. So now just to look a few published papers to come to a conclusion what we should do in a management of a simple pterygium or a recurrent pterygium. So in bare sclera technique, we know that there is a high 88% recurrence rate, so it is unacceptable. It can be combined with adjuvant like MMC, the recurrence rate definitely reduce, but there are fatal complications of MMC, so you should be using MMC very judiciously. And then it can be combined with AMT. Simple AMT is definitely not giving any advantage. It has to be combined with CAG or CLAG, or it can be also combined with MMC. And this special technique of Penislate, Dr. Sangwan published a paper in pterygium management. And whether CAG or CLAG, it has been shown that CLAG has got probably slight advantage over CAG only in recurrent cases, not in simple pterygium. And graft fixation, suture or glue, definitely glue has been established that it gives the best possible outcome, and the alternative of glues like autoblood or Botoclot can be used, but they have to be assessed in the long run. So to sum up, pterygium is not only a degenerative but also a proliferative process. Surgery should be the first line of management. Conjunctival autografting is time-consuming surgery but has the best possible outcome with minimum fatal complications. Fibrin glue graft fixation is faster and produces less recurrence than suturing. Suturing should be avoided whenever possible. So take-home message from this gathering for this gathering is that conjunctival autografting is the gold standard both in primary and recurrent pterygium. CLAG may be better than CAG in recurrent pterygium. For double-headed pterygium, either do a CRAG or CLAG and CAG. CAG plus AMT has better outcome and lesser complications than CAG plus MMC. MMC should be used very judiciously with lowest possible concentration and minimum duration. For multi-recurrent pterygium, there should be a combination of 3 CAG plus AMT plus MMC. Fibrin glue is the best graft fixation technique. Suturing should be avoided as much as possible. Autoblood or Botoclot may be viable alternate tissue adhesives in selected cases. Cataract with pterygium, you have to decide about sequential or simultaneous surgery. Thank you, and thank you everybody in the audience who have joined and encouraged us for this presentation. If there is any question, 5 minutes we have. Yes.
In cases of recurrent pterygium, which is better, using mitomycin C intraoperatively or using topical mitomycin C postoperatively?
Always mitomycin C single use has less toxic effect than multiple use. So either there has some reported cases that they give a preoperative injection of mitomycin C, say 2 weeks before surgery or 1 week before surgery, and after that do the surgery.
What is the concentration of
Again, lowest possible concentration.
and it is given like
Just
subtenon?
subtenon. Shobanda.
Dr. Sarkar, excellent presentation and everything, but I do wonder to share my own experience.
Yes, please.
What I have learned 47 years back in 1979 from my teacher, Professor I.S. Roy, who is still living 97 years old. I am still practicing that one and find it very much satisfactory for me as well as for the patient. Nothing other than Macrenner's transplantation. Macrenner's transplantation is very easy to do and very much reward, and recurrence is very minimal.
Recurrence is definitely minimum, but sir, only thing is that cosmetic blemish.
A bit for the few days, but
Yes.
afterwards the healing is perfect and others, and even beautiful skin in the cornea can be clear cornea.
For corneal thing, this Diamond Bar also has done an excellent thing for surface reorientation after surgery.
Community orientation in rural background and other, due to all the amniotic tract and other things, sometimes found it difficult.
My advice is only thing that bare sclera technique should be avoided and suturing to be avoided as much as possible. If botoclot comes out successful, then it will be a very good alternative for tissue adhesive, very cost effective alternative for tissue adhesive. Yes. It's a 15 ml pack cost around 230 to 250 rupees.
What are the logistics? Are you advising patient to bring or you're
Right now, because we are in a very initial stage, we are not asking patient to bring anything. We are purchasing from the hospital and using them. In the long term, we maybe increase a bit of surgical charges to include that cost.
And so one more question. In case of
Only one company, Jugat Pharmaceutical or something like that, only one company in India provides botoclot. Any medicine shop, this actually was used in to prevent international bleeding during any surgical process. Even in DCR surgery, we sometimes use, if there is excessive bleeding, we just put drops from outside. It's been in use for long time for different purposes. For pterygium, it's being used very recently.
my question is related to fast track with pterygium.
Yes.
In what extent you have accept the astigmatism when we are doing a pterygium with a cataract, like a grade 3 pterygium, even though keratometry they have never done that type of cases, grade 3, grade 4, grade 2. But what your extent that we have two post surgery at one sitting, what type of astigmatism you have accepted that patient?
One thing is clinical assessment in the slit lamp. You can see whether there is much flattening of the cornea by pull of the pterygium. If you suspect that there is much flattening, much tightening on that, so better do a topography if possible.
Regarding keratometers, my question is regarding keratometry.
Keratometry is not much useful. Keratometry takes only from the central corneal part. So it will not give you an accurate result regarding this thing. So either you do a topography or you don't put premium lenses at least. You can put monofocal lenses. In that case, you will not have a refractive surprise afterwards. That's I'm saying. Put a monofocal lens. Don't put a premium lens.
And so one last question. In cases of double pterygium, isn't it better to use conjunctival autograft at one side and amniotic graft at the other? rather than
Simple amniotic graft is not a good outcome. Simple amniotic graft for as a grafting is not a good outcome. You have to put something along with amniotic membrane. Very, very high recurrence rate. It's not very useful.
Membrane grafting where you cannot harvest the graft from upper conjunctiva, then only you have to go for this amniotic membrane and then put micromycin C only in that case also I put micromycin C. And then you can take some sort of limbal tissue from other sides and
other than
other eye or from the same eye also.
There is double pterygium.
okay.
Have you any experience with the placenta in spite of this amniotic membrane placenta?
Wet amniotic membrane. Yes, not dry one. Preserved one, not the preserved one. Freshly harvested amniotic membrane. Yes. One minute, please. 1 minute. Please.
In case of double pterygium, when we should not operate in one sitting, what are the criteria?
Only if you think that you cannot harvest enough conjunctiva for both sides. Otherwise, there should not be any criteria like that. You try to do it at one sitting.
If there is sufficient conjunctiva that can be harvested from the both the sides, but the post-operative chances of necrosis?
No.
Because
No. If you don't include the limbal stem cells in both the grafts, if you don't damage limbal stem cell area so much, then there is no chance of necrosis. Yes, please. Botoprase, in the name of botoprase, it's injection only available. don't use the injection. You use the topical solution that is available in the name of Botroclot. Botroclot topical solution.
So there are drops also available.
That will be the same thing. They are initially they are the same. Probably some other company has come out with this Botrophase drops.
Used in our center.
No, sir, only one company.
Ye-
Farm.
Yes,
I'm using for DCR.
that same thing you can use for Pterygium. Yes. Okay, thank you everything everybody. Yes.
One last question. Do we need voter registration for using wet amniotic membrane?
You have to need a registration for harvesting that. No, no. If it's readily available, you can use it. Thank you.
I'm still a resident in training. I was just curious. Sometimes even after a lot of effort, we cannot take a proper graph that will cover the this one. In your videos, you said we need to oppose the margins very precisely.
The first condition is